Good morning, afternoon, or evening. This is my PowerPoint presentation on borderline personality disorder for Liberty University Psychology 430 Abnormal Psychology course. The DSM-5-TR describes borderline personality disorder, otherwise known as BPD, as a personality disorder outlined by patterns of instability in interpersonal relationships, affects, self-image, and impulsivity. Other diagnostic criteria include frantic efforts to avoid abandonment, recurrent suicidal or self-mutilating behavior, instability of affect, chronic feelings of emptiness, and inappropriate anger. BPD has a high comorbidity with bipolar 1 disorder. Psychotic-like symptoms may appear in individuals with BPD. The goal of manipulation in BPD is to gain nurturance rather than power, as is more common in antisocial personality disorder. BPD tends to remit with age, be more frequently diagnosed in women, and manifest as self-sabotage at the time a goal is about to be accomplished. I believe the exact example that was in the DSM was if an individual with BPD is about to finish their degree, they might perform worse in classes in order to not actually attain the goal, rather preferring to be in a perpetual state of seeking and never attainment. According to Caviccioli et al., one of the causes of BPD include the three domains of underlying liabilities to develop psychopathology, invalidating relational experiences, and regulatory mechanisms of emotions and behaviors. This is what they analyzed during their meta-analysis, and they did find that all of them were contributors, but that none of them played a dominant role, and that they all formed a dynamic interplay in the formation of BPD. Moving on to BPD treatment, Stouffer's Winterling et al. Sought to determine the effects of standalone and add-on psychotherapeutic treatments for BPD. They found that standalone treatments had low certainty, while add-on treatments overall were found to have beneficial effects. The low certainty was whether or not the treatments had a beneficial effect or if there was no correlation. Dialectical behavior therapy, DBT, was found to significantly reduce self-harm occurrences. Mentalization-based treatment, MBT, was found to significantly reduce self-harm and suicide-related instances. Setkowski et al. Conducted a meta-analysis of randomized controlled trials that compared the effectiveness of psychotherapies for adults with subclinical BPD, DBT, MBT, and schema therapy, otherwise known as ST, were found to be significantly more effective than treatment as usual, TAU, and group therapy regarding severity of BPD, but none of the three were found to be superior to any others. The study concludes that specialized psychotherapies are to be preferred in treating adults with subclinical BPD. Moving on to prevention. Cass et al. Conducted a longitudinal study that examined the effects of early intervention on BPD criteria in adolescents over 2 years. Early intervention showed an exponential decrease in BPD criteria. Older adolescents showed the largest decrease in BPD symptoms, but benefits were found for all ages of adolescents. The study concludes that interventions should begin as early as possible and that no age is too early. Now for the sociocultural information regarding BPD. Amistoy et al. Conducted a study with 295 participants that tested BPD symptomatic behavior, diagnostic disclosure, and gender on stigma. Participants were given vignettes to read and then given a follow-up questionnaire. The study found that stigma was greater with symptomatic behavior than the label of BPD alone. Adding the diagnosis of BPD to symptomatic behavior did not significantly increase stigma, and adding the BPD label to normal behavior did increase stigma. Men were found to receive anger as a response to symptoms that women received pity for. So there is a differing response in the questionnaire for the exact same behavior depending on the gender described in the vignette. The study concluded that observable behavior appeared to be a stronger indicator of social stigma than the diagnosis of BPD. The label of BPD can enhance social stigma, but the symptoms are the main driver of the stigma. Now for the biblical focus. In the King James Bible, Galatians 6:2 calls Christians to bear the burdens of others. This bearing of burdens without condemnation would prevent the stigma associated with the symptoms of BPD found in others. Regarding the treatment of BPD, 2 Corinthians 5:17 tells us that we are made new in Christ. This transformation is reiterated in Romans 12:2. This is not to say that the transformation requires no input from the individual being transformed, as Philippians 2:12 calls for believers to work out their salvation. This would align with the necessity to partake in DBT, MBT, or ST that these slides have covered. Quick note, I understand that there are many different denominations of Christianity and that some do not like to focus too much on the necessity to work out the salvation. I am only writing this from my faith background, which is Eastern Orthodox Christianity. This concludes the presentation. Here are the references used throughout the presentation. Thank you for your time.